nice to be here this evening. And if anybody can join us or is watching this later, I think it's going to be really informative and helpful. So I'm introducing Dr. Hogan Camp, who is from New York. I think, is Clinton in upstate New York?
It is, yeah.
Not sure where, yeah.
Near Utica. Yeah.
Near Utica. So Dr. Hogan Camp, before he went to medical school, taught chemistry in Austria, went to college in upstate New York in Syracuse. Med school in Syracuse.
Right.
Did a residency in Syracuse and has been in private practice in Rutland since 1999 with your wife, right?
Right.
And that's a huge achievement. That's a long time to be in private practice.
25 years of practice together.
It's amazing. So you know your community well, and you know your patients well, and they trust you with all kinds of different things because family doctors do everything. And we look forward to hearing your presentation, and I hope that people find this informative. I'm coming to you from the Vermont Academy of Family Physicians, representing all the family docs and family medicine providers across the state. And just hopeful that we can have a conversation that maybe eases some concerns or hesitations with regards to COVID vaccinations and other topics along those lines. So thank you for being here, Peter.
Hey, thanks for having me. I really appreciate it. And I wanted to start off my presentation with two quotes, which I think are really helpful for kind of understanding not only the virus, but actually where we are in our response to the virus. And my first quote is that comes from Sir Francis Bacon. It's one of my favorite quotes because it applies to everything. And it's that man prefers to believe what he prefers to be true. And I'm going to come back around to that when we talk about the response to the vaccine, but just want to say it one more time. Man prefers to believe what he prefers to be true. The second quote is actually a Martin Luther King quote, and I kind of changed it around a little bit, but Martin Luther King said that injustice anywhere is a threat to justice everywhere. And I was thinking about this presentation. I thought to myself, that really kind of fits nice into this whole virus debate, because contagion anywhere is a threat to health and wellness everywhere. And I'll say that one more time. Contagion anywhere is a threat to health and wellness everywhere. So I wanted to start off after those two quotes with talking about a little bit of virology. And that's my dog. Apparently my dog doesn't want to hear about virology. Hey, Lise, could you grab the dog? Anyway, I remember virology in medical school, which was a long, long time ago. And as I remember sitting in class learning about virology, I thought to myself, when am I ever going to need all this stuff that I'm learning right now? And 30 years later, I realized that, all that stuff I learned in virology was super helpful. I'm not going to give you the details, but I want to give you a couple quick pointers about virology, because if we understand what a virus is and how a virus spreads, I think it's going to help us in our response to it. So the first thing I wanted to tell you is that a virus is an obligate cellular parasite. And in fancy terms, that just means that a virus can't live on its own. It has to live inside a compatible host. And for the COVID virus, we humans are compatible hosts for sure, but it can't exist on its own. It's only with compatible hosts. So keep that in mind. When we first came out with this epidemic, in March of 2020, there was all this concern about, being the virus on objects and on surfaces and this and that. And there is some, it is transmissible somewhat from that, but by far the bulk of viral transmission is in the air, where you're breathing in droplets of the virus that come directly from one host to you. The virus can't live long periods of time outside of you. So it has to have a host to live in. And that's an important thing we're going to get back to in a second. The second thing I want you to know about viruses is that a virus doesn't want to kill you, because as I mentioned, a virus, it has to have a compatible host. If a virus infects me and I die and I can't infect somebody else, well, that virus isn't going to actually succeed. So the most successful viruses are viruses that are transmitted easily between hosts, but they're not deadly, because the deadly viruses kill the hosts that it is trying to use to spread to everybody else. So keep that in mind, especially as we talk about the Omicron virus coming up very shortly. The virus needs you as a host, all right? It can't live outside the body. So the second thing you need to know about viruses is that they're constantly mutating. And we've seen this. We certainly heard it on the radio, we've heard it on TV, but what does it actually mean? It means that as the virus replicates, the more it replicates, the more it mutates. It's looking for a mutation that's going to make it a more successful virus. And what the great majority of mutations from the virus actually make it a less successful virus, and those mutated strains simply die off. But the 1 in 10 billion mutated strains that are more successful, those ones rise to the forefront. And that's what we've seen with the COVID virus, with all the different variants that we've had, the Alpha variant, the Beta variant, Gamma variant, the Delta variant, and now the Omicron variant. These things were mutated strains that were more successful than the strains prior to that. And so they rise to the top. They become the ones that are predominantly circulating in the population. Keep in mind that not every variant that we see is going to ultimately be very successful. For instance, I remember when Delta was just coming out, I read an article in the New York Times about a Lambda variant, and it said the whole idea of the article was that the Lambda variant was going to make everything we knew, or was going to make Delta a laughingstock, but that just didn't pan out. The Lambda variant just died off very quickly. And we all know that the Delta variant is by far right now the predominant variant. So there is a little bit of a waiting game with these. We have to see, what time tells us. For instance, when we get back to this Omicron variant, I want to talk about that in a little bit. The Omicron variant is definitely more transmissible than the Delta variant, and that's a big part of a virus's success. We don't know. There is no data. Let me repeat this. There is no current data as of December 1st at 7 p.m. that the Delta variant is going to be more dangerous or more deadly than the other variants. Remember what I said before about a virus's success. Viruses don't want to kill their hosts. That makes it less successful in general. So just because this virus is more transmissible does not mean that it's also going to be more deadly. So please keep that in mind, especially with, as we wait over the next couple of weeks to take a look at the data. I was just doing research before this talk this evening, and there's observational data, which tends to be very weak, that the deadliness of the virus or how dangerous it is in terms of causing hospitalizations, ICU admissions, and deaths, that it's no different or perhaps even less than the Delta variant. But again, we have to wait 2 to 3 weeks before we learn that. But the point I wanted to make to you is it doesn't have to be that way. And again, the virus doesn't want it to be that way. So now that we've talked about a little virology, and I've bored you stiff talking about virology, but again, that's important information to have as we talk about the vaccination, our vaccination efforts to get rid of the virus. We're going to remember what I said, that viruses can't live on their own. Therefore, they need to have hosts. So if you're a virus and you're walking into a hotel room, or you're in a host who's walking into a hotel room, and every single person in that room is immune to the virus either through vaccination or through previous disease, you're not going to infect anyone in that room. And that's what we're trying to achieve. This is what we talk about when we talk about herd immunity. In other words, so many people so many of our members of the herd, in this case, we humans, that the virus simply can't take foothold in the herd because so many of the herd are vaccinated. Traditionally, we've seen this number at about 60, 70, sometimes 80%. It depends upon the individual virus and how transmissible that virus is. And I remember listening to Dr. Anthony Fauci when he was talking, a long time ago about herd immunity at maybe 70 or 80%. And what he was doing is he was basing that on previous viruses that we studied in the past. But as we all know, the COVID virus, the COVID-19 virus, is a novel virus, which means that it's new. Because it's new, we don't have that much information on it. And so we're taking a guess. We're making educated guesses. I tell this to my patient all the time. Oftentimes my diagnoses are educated guesses. We're based on our study of previous viruses. Well, I think what happened with the COVID vaccine or the COVID-19 virus is that it's so transmissible that the herd immunity number has to be a bit higher than we had in the past. There's been some smaller studies on isolated groups of people where the immunization rate was 95, 99%. In those communities, they appear to be virus-free. So, there are some data to suggest that if we can get the immunization rate up to 95%, we can perhaps get rid of the virus. And it just goes to show you how transmissible this virus is that in other viruses, we were thinking, 80% would do it, 70%. Now we're looking at maybe 90, 95% to try to eliminate the spread of the virus. 95% immunity is extremely hard to get to. And as we're talking, we sit here in the state of the union has the #1 vaccination rate, and we're still well short of 95%. We're getting there, but we're still short of that. So if we can't get to 95% immunity rate, is it a lost cause? And the answer to that is definitely no, because there's a second thing that we need to look at. There's a second goal for us. And that secondary goal, which is much more reachable, by the way, is if we can prevent the virus from causing serious illness. In other words, if we can limit the virus's effect to minimal symptoms and prevent serious illness, then in many senses, the pandemic would then be over. For instance, if the virus did not cause serious illness, as defined by hospitalization, ICU admission, and death, those are the three things that we categorize as being serious illnesses. And it only caused people to have respiratory symptoms that they could deal with at home, then we wouldn't even really be even having this conversation. If COVID had never caused any of those problems, if it was just a much more indolent virus that only caused traditional cold symptoms, there would be no pandemic to begin with. And if we can bring those symptoms back down to minor illness, then in my opinion, and in the opinion of many others who study these things, the pandemic would essentially be, for all intents and purposes, be over. So again, keep in mind now that serious illness is defined as hospitalizations, ICU admissions, and death. So now that I've mentioned that as a goal, I'm going to bring up the vaccine. And if there's one thing that the vaccine has been tremendously successful at, it's preventing serious illness. I'm going to talk about two states briefly here. Those states are Minnesota and Washington State. And I use those two states specifically because they keep the most detailed data on COVID illness rates. And just to kind of shrink this data down into a little one sentence thing that we can all listen to and remember, in the state of Washington, if you are under 65 and you are fully vaccinated, the death rate from COVID is essentially 0. I'm going to repeat that because it should be a tremendous boost to you. That means if you're under 65 and fully vaccinated, that your chances of dying of the COVID infection is essentially 0. In Minnesota, they have the similar data for people under 50. If you're 50 or under and you're fully vaccinated, you have almost no risk of dying, almost 0 risk of dying from COVID. That's great news, because if you have no risk of dying from COVID, I think the fear of the illness is going to, and the hysteria that's kind of plaguing us as well, is going to come way down. I list those two states because they keep the most detailed data, but there are many states' data that have essentially the same kind of statistics. The vaccine works tremendously at preventing serious illness. And so that to me is our secondary goal. The secondary goal is, well, if we can't stop the spread of the virus entirely, then we can at least prevent the risk of serious illness in people who are vaccinated. The Achilles heel to this plan is that, as I mentioned, This data is for people who are 65 or under and fully vaccinated. So for people who are 65 and over and still fully vaccinated, those people still do have a risk of serious illness despite being vaccinated. And that's because they're older. They may be sicker, they may be frailer, they may have comorbidity such as obesity, diabetes, heart problems, lung problems that make them more susceptible to serious illness. They may have immune compromise. They may be taking medications that make them immune compromised. So the secondary plan isn't as good because there's still these people who are vulnerable. There's still this vulnerable population. And as a physician, I have the great privilege of taking care of many elderly folks, and I'm very attached to them. And I don't want to see them go under with the virus. So although the secondary goal of decreasing serious illness and essentially getting rid of it works for me, it doesn't work for everybody. So there again, we want to go back to the first goal, which is to get everybody vaccinated so that we can prevent the spread of the virus, so that our vulnerable people are at much less risk. So I tell people, if you have a grandmother, if you have an Aunt Judy that you love, if you have your neighbor who you love, we all have someone who's vulnerable to this virus despite being vaccinated. We all have someone in that subset in our lives. Get the vaccine for them. Yes, you should do it for yourself, but if for whatever reason, you don't want to get the vaccine for yourself, I'm asking you to get your vaccine for your neighbor Lloyd, who's 95 and who's a wonderful human being and who the world is much better place for him being there. Do it for Lloyd. Do it for your sister who has rheumatoid arthritis and she has to take immune suppression medicines. So if you don't want to do it for yourself, and I do understand that some people have chosen not to do it for themselves, do it for somebody else. Do it as an act of great kindness and generosity. So when I tell people this, and I tell people this all the time, they'll say to me, well, you know, am I going to be putting myself at risk for everybody else? And the answer to that question is no. You will not find any data anywhere to suggest that this vaccine is unsafe. This vaccine is a very, very safe vaccine. The CDC, the WHO, the AMA, all these organizations who are comprised of people who study these things for a living, they have all come out and said there are no safety concerns from this vaccine. And what I mean by that is that the rate of significant issues from the vaccine is at an acceptably ultra low level. That does not mean that your arm won't be sore after getting your vaccine. That does not mean that you might feel, like you've got a mild flu the next day. All these things can and do happen. We have many patients in our practice. Almost all of them have been vaccinated. I listen to their stories. Everybody will say, yeah, I felt okay, or maybe I felt a little punky, but it's very short-lived. In our particular practice, we didn't have any significant side effects from the vaccine. So when you decide to do this nice thing for your neighbor Lloyd, for your sister Judy, for your grandmother Pearl, these people that you love, and you want to see them continue to exist on Earth, do it knowing that you're not putting yourself at risk. This is a safe vaccine. So with that segue, I want to talk about the next thing, which is the booster. People ask me about the booster all the time. And my answer to the booster is this. This darn COVID vaccine, or this darn COVID virus, is a tricky little virus. One of the things that it does is that, because I think we've never seen any virus quite like it, when we form antibodies to them, they don't last very long. So what I've seen and what we've seen throughout the country and the world is that vaccine levels or antibodies are these small little particles in your bloodstream that are formed by the vaccine or previous infection, and they are there in your bloodstream. If you're exposed to this virus again, they're there so the virus doesn't infect you, doesn't take hold. And when those levels are strong, for instance, 2 weeks after vaccination, when they are the strongest, then people don't get infected at all. And we're getting back to the original studies on the Pfizer and the Moderna vaccine that came out and at 95% effective at preventing any illness at all from that vaccine, which is amazing. Amazing. So some of the flu vaccines have efficacy rates of 50 or 60%. This is a 95% vaccine rate. It's a tremendously efficacious vaccine. I'm still amazed at how effective it is. Unfortunately, all that data was done with the original COVID vaccine. When the Delta variant came, things changed some. But again, this is where the booster comes in, because as those vaccine levels, those antibody levels drop with time, and your risk of infection goes up with time after the vaccine, you can get a booster. And the booster then restores the vaccine, even with the Delta variant, to its original effectiveness at 95%. What we've seen here in our practice is people who have been vaccinated, again, they may get sick. We have had very, very few instances of serious illness among patients who are fully vaccinated, and all of those in a patient who are in those previous vulnerable groups that I mentioned. But we care about those people too. So keep that in mind. We don't want to dismiss them. It's just saying they're a vulnerable population. We want those people to be healthy and well as well. So as that vaccine becomes less effective, we then boost it. And so when you get the booster, 2 weeks after that, your antibody levels have risen up to that nice, robust level where we don't get any illness at all. And the nice part about that is, if we're not getting any illness, we're not transmitting it. So the data on the booster and its effect on transmission, those studies are still being done. But in general, and again, these data are going to come out, and we have to listen to this data, because we haven't always been right in our predictions about COVID. And that's the most important thing. The lesson that we've learned from this is, we make predictions, but then we follow the data, we follow the science, and we listen to the science. We don't listen to anything but the science. Because when we listen to other things other than the science, then we get into all this other stuff, like people not wanting to get the vaccine, and misinformation. And misinformation is deadly. It may not be deadly to you, but it may be deadly to your neighbor, who's, again, the one with the immunosuppression drugs for rheumatoid arthritis. So the booster, in my opinion, is very valuable. I suggest everybody get it. For those of you who aren't sure if you're eligible for the booster, I'm here to tell you that you are, because the current recommendations are for all people 18 and above who've been vaccinated, who had their second vaccine 6 months ago or further from that, or later, earlier than that. Those folks are eligible for the vaccine, for the booster, and they should get it. They should get it for themselves, because when they get the booster, they're even more likely to not get the disease at all. And if you don't get it, then you're not spreading it. And they're also less likely to spread it to their neighbor. So I'm a big fan of the booster for those reasons. So I wanted to go back here. And Stephanie or Katie, if you have any questions, or there's any questions out there, please let me know. I'm happy to answer any questions. I answer questions all day long about this. I'm happy to do it. To me, the biggest weapon against this pandemic is accurate information. It's accurate information. And the biggest concern, the biggest enemy that we have is misinformation and things that just simply aren't true. I see Stephanie popping up. Did you have a question for me?
I have a couple of questions in there, but I was just going to urge people to use the Q&A, the little box on the bottom of the Zoom toolbar. So if you do have questions, keep typing them in. And then what I thought we could do is, when you finish with your information, we can have a little round robin, because we have now been joined by the Commissioner of Health, Dr. Mark Levine, and maybe we can have all of you with Dr. Marvin answer some of the questions.
Yeah, so I'm basically done with my presentation, and my wife said, Peter, if you talk for more than 25 minutes, she's going to turn the computer off. So let's go to the round table.
Great, perfect. So I will just spotlight everyone. So I'd like to just welcome Dr. Levine. I don't know, Dr. Levine, if you'd like to say a few words or if you'd like to just run right into questions.
Dr. Hogenkamp has done a phenomenal job, and I'm gonna abide by his rule that we've done enough talking to people, and now we want to interact. So let's let the questions begin. Wonderful. They don't have to be questions; they can be concerns too. Anything that people want us to respond to.
Absolutely. Anything you have to, anything on your mind, please type it in the Q&A box. It can be anonymous, so you can type in anything that you would like, and I will pose that to our panel. So I think one of the first questions is, you talked a lot, Dr. Hogenkamp, about the studies and that a lot of people looked over the studies, but it seemed like it was really a short amount of time and a really tight turnaround. So how do we know that there won't be side effects or things that come up in the future from the vaccine?
Mark, how about you handle that one?
Sure. I think that question is a variation on the theme. Operation Warp Speed went really fast. And why should I trust vaccines that were made so quickly? So part of the answer to that is that even though it seems like it went very fast, this messenger RNA technology, which is new to most people because they never had a vaccine injected into them before with that technology, is terribly new and experimental. And the real truth is that it's not new and experimental. It's been around for over a decade, and it's been researched during that time. Prior rarer infections than COVID have been actually used to develop vaccines against them with the messenger RNA. Currently, companies are looking at doing flu vaccine with messenger RNA. So this is now an accepted, if I could call it, standard of care that has proven over time to be worthy of our attention and not fear, but worthy of our respect, because a lot of time has gone into this research. The fact that these vaccines that we're now using are new and they don't have decades of years experience, because we didn't have SARS-CoV-2 on the planet till a little less than 2 years ago, isn't that much concerning, because we now have hundreds of millions of doses given in this country, around the world, and we're not seeing the kind of effects that people are most worried about. Sure, we're seeing people whose arm hurts, who get a fever, who get some malaise when they got their shot, and that's gone within a few days. And certainly nothing is lingering longer than a week, for sure, for that. But people are concerned about, am I going to wake up in 8 months and have 6 fingers or some other side effect that nobody told me about because these are so new? And now we're so far into this. In this country, we've been doing it since January, so it's almost a full year. In the clinical trials, add on the 6 months that came before that, when those trials began, and nobody is seeing long-term effects that would be concerning to people resulting from getting vaccinated. In fact, what they're seeing is long-term effects from getting COVID before people got the chance to get vaccinated or who chose not to get vaccinated. And the likelihood of getting long-term effects from having a COVID infection are way more than having any long-term effects from having gotten vaccinated to prevent the infection.
You know, Mark, I like your point. And when I was researching this today, I looked up the number of vaccines that have been given worldwide. It's over 4 billion. Over 4 billion vaccine doses have been given. And, when people say to me, well, I don't know what's going to happen, I'm like, well, listen, we've given 4 billion doses. And we are seeing tremendous safety with these things. And again, this isn't 20 years down the road, but the likelihood of something happening 20 years down the road from a vaccine like this, we just haven't seen like anything like that in modern medical history. The other thing I always tell people is that everything in medicine is about risk versus benefit. Risk, benefit, risk, benefit. Is there some risk to this vaccine? There is a slight risk. It's very, very low, but it's a slight risk. What is the benefit of the vaccine? The benefit of the vaccine is it prevents you from getting COVID and getting serious illness with COVID. Again, about 1% of people, these numbers are they're different depending on where you look, but this virus has a 1% mortality rate. That means 1 out of 100 people that get the virus die. So the benefit of that vaccine is that you're now taking yourself out of that group. The other thing is, as you were talking about, all these COVID long haulers, these are people who had COVID, survived COVID, but are now having long-term symptoms from COVID. The vaccine, again, is going to prevent that risk as well. So the way I look at it is, if you're looking at this in a scientific fashion, the risk benefit of getting the vaccine comes out heavily in favor of getting the vaccine.
One thing I was going to say, if you can hear me okay, I was in clinic today and yesterday, and I saw quite a few people, patients I know really well, who are not yet vaccinated. And I always try to dig down into sort of the why and try to find that common interest that we both have. And it's zero judgment. I mean, I think patients have hesitancy but they're good people, they're good parents. And I have to kind of think to myself, why? Like, where did the trust break down? Especially, we can go through those numbers, and I can put myself out there and say, I was one of the first people to get vaccinated in our county because I wanted to make sure that if there was anything wrong with it, that I put myself out there just to see. And then I got my kids vaccinated right off too, just to sort of show, like, I trust this. And I hope that helps people trust it as well, because I'm really, really comfortable having my own 3 girls get the shot who are all pretty young. But I also sort of still have to question, like, what is the concern, and value that concern, and at least honor that concern where it exists, because, people have that concern, and what we can do. And one of the things that's worked for me is to share those personal stories of myself and my kids, because, people know me, they know I'm not going to do anything to my kids that would be harmful. And when I do get those questions about sort of the speed that it occurred by, and the Operation Warp Speed, one of the things that I'll say is, it took a long time to invent the automobile, but now that we know how to do that, we can make lots of different kinds of automobiles fairly quickly. So we're really modifying technology that we understand better now because we've had it for longer. We've had vaccines for a long time. We kind of get it. And we also recognize the vaccine itself, and Dr. Levine would probably be able to give me the number of hours that it's actually in your body. The vaccine itself is not in your body all that long. It really gets looked at. Your body kind of goes, whoa, something new. Let's remember that. Let's make a blueprint in our head. Well, now we're going to create a little reserve army that we're going to stick away somewhere till we use another time. But then it kind of gets rid of it really quickly. I don't know how many hours, but it's not that long that you actually have that vaccine in you. And it's not actually the virus that's in you. It's the vaccine that's in you. So those are like my little pearls that sometimes help with my conversations with patients, just to kind of try to meet people where they are and understand that there's hesitancy, perhaps just from just concern for their own safety and their family safety. And I have to value that. That's not coming from a bad place. But I sometimes it helps get people a little closer. And I've had plenty of people that then said, oh, I was going to get vaccinated a month or 2 from now, but I may as well just get it now so you stop bugging me.
And now it's in your primary care office, so you can do just that during that visit and when you have those questions. So
we do perfect. We do a lot of vaccinating, a lot of boosting, a lot of conversations too.
That's been a huge help for my patients. Is nowadays, a lot of people get shots in the pharmacy as well as in our offices, kind of thing. And I much prefer them to get shots in our office, and the patients do too. So now that we have all the vaccines in our office, thank you, Dr. Levine, and we really appreciate what the state health department has done getting us these vaccines. We, my office, one day we opened up a Pfizer vaccine because someone wanted it that day, and you know what we did? There's 6 total vaccines in that vial. We ended up using them all by the end of the day. And because we just called people in our practice that we knew were eligible for a booster. It's like, listen, would you like to come to our office and get a vaccine? And that meant something to people to get it at our office with people that they knew and trusted. So I think that the delivery of the vaccines to the primary care offices was a great thing.